Let me rush towards the next interactive session where we are going to have Professor Brocklehurst, the CI of the infant trial, and we are going to have Professor Inês Nunes talk about the FMLR trial in more detail. We saw a talk from her yesterday morning already on it. So I will invite the panelists to give a brief overview of their respective clinical trials, and then please take the panel seats and then we can have a discussion. Thank you.
Thank you. Thank you very much for coming to speak about the infant trial. I'm sure you've all had a chance to see this now. I was an obstetrician in a previous life, but I'm now more an epidemiologist and have been for a long time. So I do clinical trials, but it's a long time since I've been on the labour ward. So don't ask me about anything that we do currently in the labour ward in the UK. I can tell you what it was like a few years ago, but we'll deflect questions elsewhere. So I'll talk about a little about the infant trial. Declarations of interest, just to say that I do have some declarations of interest to make. Those of you who've read the infant trial and the correspondence around the infant trial in the Lancet will know that there were a number of controversial issues. So just to say that these are my conflicts. They're non-commercial conflicts. They're all to do with grant income. And also that the views I'm expressing, just in case anybody wants to repeat them, are mine and mine alone. So I'm not going to go into any background of why we wanted to do this trial, apart from just making a couple of observations. The first being that this debate, which appeared in the British Journal of Obstetrics and Gynecology a short while ago, was quite an interesting debate, I thought. This is an American talking against the use of electronic fetal monitoring. Shall I say that again? An American talking against the use of electronic fetal monitoring, which I thought was quite interesting. But the thing that she highlighted, which I think many clinicians forget, both midwives and obstetricians, is that continuous electronic fetal monitoring is a screening test. And it has sensitivity, specificity, positive and negative predictive values, and performs just like any other screening test, and has certain characteristics that we can look at. And I think that's largely forgotten. I think clinicians, particularly midwives, sometimes think it is a diagnostic test. It tells you whether the baby is hypoxic or not. But of course it doesn't. It tells you whether there's an increased risk of hypoxia and potential for hypoxic damage. And we know that there's been lots of reports about human interpretation and the errors of human interpretation, and there's been lots of reasons put forward about why there may be errors in human interpretation when reading the fetal heart rate trace. So of course the alternative intervention is a computer-based system, which of course I think you've been spending quite a bit of time already talking about. The potential benefits of that are clearly to improve neonatal outcomes in relation to intrapartum stillbirth and cephalopathy in its broadest sense, but also we felt quite importantly to decrease intervention in labour. A lot of caesarean sections are done in labour for presumed fetal distress, or it's one of those things that people can put down and then not be criticised for the decision to do a caesarean section in labour. But if we could have a more accurate way of determining whether the baby was indeed distressed, then we may be able to increase appropriate caesarean section and decrease inappropriate caesarean section. And there are far more inappropriate caesarean sections done in labour. So it seemed like a very good idea that we should try and do this. We used the Guardian system and the infant system that was made to sit on that platform made by K2 Medical Systems. I'm sure you're very familiar with this. It's a system which sits in all the labour wards. It's effectively a notes-free environment on the labour ward. Everything can be entered onto the computer screen by the patient's bed. The partogram, all the drugs taken. It doesn't need women to have continuous fetal monitoring to be included in the Guardian system. And there's a central system which can sit in the nursing station for review of all the CTGs in the various rooms, and also people can access it remotely from home and so on and so forth if they need to review it in an emergency. It's very user-friendly. It was built with obstetricians and midwives in mind, and people like using it. And these are some of the examples. So this has what it's called a ladder of concern at the top. you can see this bit here, which is yellow. So this ladder of concern goes from green, completely normal, through to blue, very mildly abnormal, yellow getting more abnormal, through to red, severely abnormal, do something about it. Clinicians have to acknowledge this with a thumb or fingerprint to move on once they've done something. If they don't, then their alerts start getting increasingly strident and a voice starts telling people to act. Very calmly, but there is a voice that starts telling clinicians to act if people don't act on the red alerts. So I'm sure some of you are very familiar with the system. So we wanted to trial this in a randomised controlled trial, including a broad range of eligibility, so women over 35 completed weeks, over 16 with singleton or twins, because this system does not rely on detecting the fetal ECG. This can use any fetal heart rate signal that's collected digitally. So very, very broad entry criteria. It was only women who were judged to require electronic fetal monitoring. So it didn't change practice with respect to who had continuous electronic fetal monitoring. And in the UK, the NICE guidance suggests that about 60% of women will be eligible for continuous electronic fetal monitoring, and the other 40% will have intermittent auscultation. Now, in practice, it's probably more than that. With current staffing levels, it's easier to put somebody on the CTG than assure one-to-one midwifery care in labour in most labour ward units. Women were eligible at any time a decision was made to start electronic fetal monitoring, so that could be when they first presented in labour because of previous risk factors, or at any time during the labour when a decision was made to start continuous electronic fetal monitoring. At that stage, they could be recruited. We wanted a substantive perinatal outcome. We didn't want pH. pH is pretty useless, I would suggest, for deciding when babies are really sick. In a standard labour ward unit, you can see lots and lots of very, very pink healthy babies with very, very low pHs. And it may be to do with the equipment and how the blood's taken, but if you're not using a very, very carefully controlled data set, you'll have lots and lots of false positives in there which don't reflect the condition of the baby. So we wanted to get away from relying on pH and rely on something substantive, which meant a composite outcome because we knew the event rate would be very low. So we went for intrapartum stillbirth after trial entry, neonatal encephalopathy, which meant the babies were cooled or admitted to NICU within 48 hours of birth for more than 48 hours, with evidence of encephalopathy, feeding difficulties or respiratory illness and poor condition at birth. I'll just touch on that last one because it sounds relatively mild. These weren't mildly affected babies, these were very sick babies, but they didn't have the EFM changes in the fetal brain, in the neonatal brain, that crossed a threshold for them to start whole body cooling. We collected all the case notes for all of these babies who constituted this definition, and they were reviewed by a blinded panel of neonatologists who went through all the cases. And there were many, many very sick babies who came out in terrible condition at birth, with very low pHs, quite flat, needed active resuscitation, and then were admitted to the neonatal unit for more than 48 hours. So don't go away thinking that these were babies that were mildly hypoxic. These were quite profoundly hypoxic. But they hadn't got the altered cerebral function to cross that threshold for cooling at the time. And we also looked at neonatal delay at age 2 years in a subset. Our sample size calculation, which I'll come back to a little bit later, made a number of assumptions. So our event rate was low at 3 per 1,000, and we needed 90% power, and we were wanting a halving of the event rate, which is quite a big effect size. But that already needed 46,000 women to be recruited. And before I started this trial, after it was funded, I used to have to sit down when I said that, because it seemed like an unachievable aim. Anyway, as you know, we did it and we published the results. And I'm just going to talk very briefly about the results per se. We had a group of women who we expected. They were slightly higher risk than the average. They were more likely to be induced. They were more likely to be having their first baby. 6% had a previous cesarean section, 1% a previous stillbirth, more very post-term. So the sort of population we'd expect to cross that threshold of continuous electronic fetal monitoring. Just a word about conduct, because I was asked to say something about conduct. The reason we were able to recruit 46,000 women is that the whole thing was done by the Guardian system. So the Guardian system would identify eligible women and remind the health professionals caring for them, mostly with midwives, that these women were eligible. So the only piece of paper in the whole trial was the signature for the woman. So the midwives didn't need to collect any. But when babies were admitted in the neonatal unit, we had specific research midwives and nurses collecting the data. But for the midwife who was recruiting a woman and randomising a woman, there was no paper whatsoever. And they didn't have to collect any additional data. It was all routinely recorded in the Guardian system. And then those data were downloaded to us in the coordinating centre every week automatically. This allowed us to get to 46,000 with a 6-week delay. In fact, we got to 47,000 with a 6-week delay. In the last month, we recruited nearly 2,000 women. So by the time the trial got going, it was going very, very actively. The delay was the number of centres, not the number of women. And we recruited extremely high numbers of eligible women, as you might imagine, to get that far. And you know this is the results. The primary outcome, 172 events versus 171 events out of a denominator of over 23,000 in each group. That's made up of this, a very small number of stillbirths. This is stillbirths after trial entry, so I think you would anticipate that that would be small. Neonatal deaths, encephalopathy, and admission to the neonatal unit. And I'll come back to these a little bit later. Metabolic acidosis, where it was measured, we could not mandate in 47,000 women that they had to take a cord pH. We asked all centres to have a very low threshold for taking cord pH, and some centres did it on almost everybody, but not everybody did have that, and there was no difference. No difference in seizures, spontaneous vaginal births, fetal blood sampling. There was a statistically significant increase in the number of having fetal blood samples. I'll remind you that these are 99% confidence intervals. We only used 95% confidence intervals for the primary outcome. All the secondary outcomes were 99% confidence intervals. So the fact that this is a significant difference, the likelihood of this occurring by chance alone is less than 1%. As opposed to less than 5% at the standard conventional level. So this is almost certainly a real difference. It's in the decision support group. It is what we would anticipate, that them showing alerts to the clinicians changed their behaviour. They did more fetal blood sampling in that arm of the trial. Other secondary outcomes, so some of the process outcomes, which I think are quite interesting. These are the levels of concern in any women who had any level of concern. And if you look at the rate of those, in the yellow alert group, the rate of repeat yellow alerts was lower in the decision support arm. Statistically significantly lower, again with 99% confidence intervals, suggesting that in that group that had those moderate alerts, clinicians changed their practice in whatever way and prevented repeat yellow alerts happening. But that still didn't relate into improved clinical outcomes for the baby. The 2-year outcomes were no different. The deaths by 2 years were very similar. We reviewed all the deaths, apart from the early ones, which we knew were related more to birth. There was a tragic mix of accidents, injuries, road traffic accidents, and so on and so forth, cancers. But no difference between the two groups. Let's just go back to this primary outcome. We did quite a lot of work to justify the size of this trial. You can imagine going to a funder and saying, we want to do a trial of 46,000 women, and will you give us £6 million, please? That's quite an ask. So we did a lot of work trying to justify the sample size, and it was really difficult to get the data. But in our protocol, we said stillbirths would occur, the primary outcome would be 0.3%. It was 0.8%, almost 3 times higher than we had anticipated. So we had plenty of power to show really quite modest differences with a substantially increased event rate. But stillbirths were substantially lower, neonatal deaths were substantially lower than we anticipated, encephalopathy about the same, because there we had some decent data, but it was this categorisation of really depressed at birth and requiring admission to a neonatal unit where we had no handle on, which was substantially higher. And obviously, that 0.8% is made up almost entirely of this category of these hypoxic babies, but didn't go on to die or be cooled. We did, this is not published yet, we're writing the paper at the moment. Phil Steer, who some of you will know, did a quality of care review of all the of all the babies who had the primary outcome and acidosis, where 0 is no substandard care and 3 is substandard care, where the outcome could probably have been avoided if care had been appropriate. Not surprisingly, and very similar to previous KESD reports, and it'll be interesting to see what comes out next month from Embrace, about just over a third, 38%, there was evidence of substandard care which could have made a difference to outcome of these cases. How was this related to CTG interpretation? I suppose reassuringly, those the total population, I mean, this in itself is interesting data which is sometimes difficult to get from the paper, the original paper. So 11% of the total population had a yellow alert. 11% of all these women had a yellow alert. 20% had a yellow alert and 11% had a red alert. In those where there was either neonatal death or stillbirth or profoundly hypoxic baby with a very low, with metabolic acidosis, that was substantially higher, as I hope you would anticipate it would be. And it was often related to CTG interpretation. So you're more likely to have CTG or problems with the CTG interpretation in those babies where it was felt that there was an avoidable cause of death. If that makes sense. But interestingly, the group that reviewed this, who were blind to allocation, did not relate failure to detect ECG abnormalities, but a failure to assign appropriate significance to that CTG abnormality. So they recognised that there was an abnormality, didn't realise how serious it was, or didn't take anything else into account when they made their decisions not to deliver those babies early or do anything which may have avoided the outcome. So our conclusion was that in this trial there was no evidence of the difference in the risk of poor neonatal outcome using the decision support in 46,000 women. Remember that the existing Cochrane review of CTG's electronic fetal monitoring versus intermittent auscultation only includes a total of all of those trials of 33,000 women. So this is very substantially larger than the totality of evidence of trials around CTGs already. So some thoughts just to throw out there, and I'll be a bit controversial here, perhaps with this audience, very controversial. The decision support did influence behaviour. People were more likely to take fetal blood samples and there were fewer yellow alerts. So something happened as a consequence of the prompts that were being given to them. Now this could suggest that failure to recognise CTG abnormalities is not the problem. And it is probably something to do with failure to act promptly enough. I think this is a question we need to ask again, is how sure are we that fetal heart rate abnormalities indicate impending damage rather than existing damage? We changed clinicians' behaviour. We changed the way that they looked after these women even if we didn't change the mode of delivery of them, but it made no difference to outcome. So I think this should be viewed as asking us to attempt to ask some of these more fundamental underlying questions. And should we abandon CTGs? That was the controversial bit. I don't think we will, because I don't think there's any viable alternative at the moment. What I'm going to argue very strongly in a forthcoming BMJ debate about continuous electronic fetal monitoring is that we already use continuous electronic fetal monitoring far too much, and we should use it far less than we currently do. We do harm with CTG monitoring. The caesarean section rate is substantially increased. Intrapartum caesarean section rate is substantially increased. We know that, there's no uncertainty about that. Previous caesarean section is the biggest common reason for catastrophic events in the next pregnancy. Things like uterine rupture, morbidly adherent placenta, massive postpartum hemorrhage, all of which have substantial maternal and perinatal mortality attached to them. Electronic fetal monitoring has never been shown to decrease perinatal mortality. Increasing caesarean section in labours as a consequence of monitoring will increase subsequent perinatal deaths and maternal deaths. There is no doubt about that. The issue is how commonly that happens. There's going to be a report out from Embrace, which is the UK confidential inquiry system, later this month, 28th of November, which is looking at doing a confidential inquiry that we did in the same way that KESD did in 1997, so it's a long time ago since that was done. and looking at term intrapartum related deaths. So I'm sure we're all very excited to see what that's going to show. Now, I'm not saying we shouldn't monitor fetal well-being in labour. I think we absolutely should do. And I think there's a really urgent need to monitor fetal well-being. What should we invest in, though, in our research going forward? Refining our interpretation of CTGs. This screening test has appalling characteristics. The National Screening Committee in the UK, if we try to introduce this now, would not allow us to use CTG monitoring. Its sensitivity and specificity and positive predictive value are terrible. Do we really think we can turn this by lots of further interpretation and mathematical modelling into something which suddenly becomes a good screening test? It's so far from being a good screening test, it seems to me almost inconceivable it can become a good screening test by looking at interpretation of the fetal heart. There is a desperate need to do other things. We need to find a way of monitoring babies in labour to prevent these adverse outcomes. I'm just not sure that any further work on the fetal heart is worthwhile. I said I'd be controversial. Thank you.
Okay. Good morning, everyone. Thank you again to the organizing committee for inviting me here to talk to you about the FM Alert trial. I would like to thank you again because this has been an amazing meeting. It's really a pleasure for me to be here with you and to discuss this study again. So this was a multi-center randomized trial carried out in the UK evaluating the use of computer analysis of cardiotocograms. The study PIs are Diogo Aires de Campos and Austin Govumadu, who is here, fortunately, with us today. And the other co-authors are the center coordinators, Drs. Pina Amin, Philip Banfield, Anthony Nicol, Simon Cunningham. The system engineer was Paulo Souza, Cristina Costa Santos was the statistician, and João Bernardes was the consultant for the trial. And I was the data coordinator. I'm an obstetrician gynecologist doing obs and gynae every day, working in the labour ward. And I've worked in this study during my PhD work. So, as we saw yesterday, I've presented in a very detailed way the system, but just to remind you, the CISPORTO project started 30 years ago, in the late 80s. The first version of the program for computer analysis of cardiotocograms was called the Porto system, and this was one of the first demonstrations of the program, the prototype in 1988, and where you can see some of the inventors, Professor João Bernardes, Professor Van Hein, and Professor Marcos de Sá. So the system was commercialized in 2003 with the name OmniView CISPORTO. This is a central fetal monitoring station with computer analysis of the signals and online alerts involving both CTG and ST events when the latter are available. And as I showed you yesterday, here is an example how the computer briefly works. It starts by attributing a baseline, the dashed green lines here. Then it identifies accelerations in green, then decelerations here in red, and it calculates points with abnormal short-term and long-term variability. Finally, it identifies contractions here in green and uses all of this information to elicit a clinical alert that is, in this case, a red alert, which is prolonged deceleration with reduced variability, with large signal loss that we can identify as well. So it comes up with different alerts with different color code that are related to different grades of hypoxia. So yellow alert the probability is high that there is probably an hypoxia, an impeding hypoxia, but the red alert is more related to the diagnosis of fetal hypoxia. Several studies have been conducted with this system, and about 7 years ago it was felt that the time had come to plan a randomized controlled trial to evaluate the system. So the aim of the study was to determine whether computer analysis with real-time alerts reduced the rate of metabolic acidosis compared to continuous monitoring as previously performed. The 5 participating centres of the study were located in all over UK. So 1 centre from Scotland, 2 centres from England, and 2 other ones from Wales. The study protocol was published in 2010 in BMC Pregnancy and Childbirth, and the study was approved by the Cambridgeshire 1 Research Ethics Committee. These are the eligibility criteria. So women were eligible for enrollment if they were more than 16 years old, if they were able to provide written informed consent, singleton pregnancy, gestation over 36 completed weeks, key-file presentation, no major fetal malformations, inactive labor but not inactive second stage, no non-contraindication to vaginal delivery, and after decision was made to perform continuous CTG monitoring, for instance, after inducing labor, after decision was made to put an epidural on, etc. So eligible women were approached by the attending midwife when there was a clinical decision to perform continuous fetal heart rate monitoring. The study was disseminated during the prenatal care and also at hospital admission, but consent was obtained only when continuous CTG was started. So randomization was performed on a one-to-one relation, either to experimental arm, computer analysis with real-time alerts, or continuous monitoring as previously performed, and this was made using a computer-generated randomization sequence attributed by the program. So in the intervention arm, ultimate management decisions remained the responsibility of healthcare professionals, but no directive guidelines were given that I will show in a minute. CTG and ST analysis were, as well as FPS, were allowed in both arms of the trial. So here we can see some of the guidelines used to help understand the meaning of the various alerts that the system gives to the clinician. For example, orange alerts, tracing characteristics that may be associated with some degree of fetal hypoxia. Then they should consider reversal of hypoxic causes if possible, maintaining close monitoring, starting ST analysis, for example, if available, or performing FPS. So it's just a system that helps clinicians to be more aware of what's happening with the fetus and not giving the healthcare professional a directive guideline or a directive decision to be made. So the primary outcome was metabolic acidosis, defined as umbilical artery pH less than 7.25, or base deficit with a base deficit in the extracellular fluid more than 12. And this was recalculated using pH and PCO2 values using Sigard-Anderson acid-base algorithm. And then we can, of course, discuss why we chose this primary outcome and why we shouldn't use this primary outcome nowadays, maybe. Secondary outcomes, cesarean section rate overall and for non-reassuring fetal status, instrumental vaginal delivery rate overall and for non-reassuring fetal status, FPS rate, 5-minute epic cause less than 7, NICU admission, moderate and severe HIE, perinatal death, internal fetal heart rate monitoring, signal loss and signal quality. Sample size calculation was based on the incidence of metabolic acidosis at St. George's Hospital, published in a British Journal in 2007, which was 2.8%. And the estimate of the degree of change was taken from the STAN data for the lack of a better alternative. So the estimated study sample size was 8,133 patients for an expected duration of 3 years. A pilot analysis after first 1,500 cases was performed to evaluate real incidence of metabolic acidosis, observed change, and need to recalculate the sample size. Cases with metabolic acidosis, low 5-minute APGAR scores, or NICU admission were further investigated according to these outcomes. So, blood analysis in first hour of life, neonatal encephalopathy in the first 72 hours, other complications that may have occurred in the first 7 days, brain ultrasound or other imaging techniques in the first 7 days and its alterations, and death in the first 28 days. Data analysis followed the intention to treat principle, and missing data, defined as no artery and no vein pH, could still be classified as metabolic acidosis if acid base in the first hour of life showed a lactate of more than 10. This is the trial profile. So patients assessed for eligibility were 32,306. 7,730 were enrolled and randomized, 3,961 to the experimental arm and 3,769 to the control arm. Cord blood gas values were available in 87% of the cases, 69% of which we had both results, artery and vein. Main demographic, gestational labor characteristics were similar in both arms of the study, as expected, and as Peter said before, here we could also find a pretty high-risk population. So most of the patients had epidural, most of the patients were induced, so it was not, well, a very good representative of all population. So in the cases we had with metabolic acidosis were very few. So 16 in the experimental arm, 0.4% of incidence, control arm 22.58. With the trends, it was better performance in the experimental arm, but with no statistical significant difference. Secondary outcomes. Well, to test for consistency of primary and secondary outcomes across centers, mental nasal homogeneity tests were performed. Heterogeneity was found only for overall instrumental vaginal delivery rate and on adjusted relative risk. The results were similar in both arms, so no differences. In subgroup analysis of laboring women with pre-existing medical conditions or complications that occurred during the current pregnancy, a significantly lower incidence of newborn acidemia, so pH less than 7.10, was observed in the experimental arm. So it might be useful in this subgroup of patients. No difference was seen in the subgroup of patients monitored with ST analysis. And over the course of the study period, a significant decrease in the rate of cesarean delivery for non-reassuring fetal status and instrumental delivery for non-reassuring fetal status was observed, which I think is interesting because we are always worried about increasing intervention where they are not needed. So some points for discussion that I think it will be very interesting to spend some time in here afterwards, after I finish this. So, and some of them have been raised already by Peter Brocklehurst. So one of the things is that the response to computer alarms is still very complex in nature, and therefore clinical outcomes are very dependent on staff performance, on staff behavior, on staff response to the alerts. And it's very difficult for us to analyze and prove that if healthcare professionals were actually looking at the system and re-evaluating the system, reassessing the baby, reassessing the clinical condition, and how that influenced the outcomes. Another thing is the unexpected low rate of newborn metabolic acidosis that suggested the occurrence of the orphan effect. So increased attention to fetal monitoring and subsequent management during the study in the control group, motivated by the knowledge that the study is being undertaken. And we tried to compare what happened in the study population with the population, with the general population of each hospital. It was not very easy because some of the hospitals didn't have that data to send to us, but could have been a way of proving if there was or not, and not the orphan effect, but we suspect that there was. Of course, similar findings have been shown in other studies regarding intrapartum fetal monitoring, and we perhaps have to think about other type of design studies to prove that, or probably we are not. Maybe fetal heart rate evaluation is not the answer. We don't know. So in conclusion, I would like to say that continuous monitoring of CTGs with computer analysis and real-time alerts is associated with a low incidence of metabolic acidosis, and that's for sure, and does not increase intervention rates that we could show in our study. And it's probably helpful in a subgroup of patients, a subgroup of very high-risk patients. However, there is no clear demonstration of benefits when compared with visual analysis. Maybe a larger sample size, similar trial in centers with less experience may be needed, I don't know. And I would like to remember you, I said yesterday that 2 of the centers, they conduct regular intrapartum fetal monitoring courses, so they are centers with very keen on intrapartum fetal monitoring. So maybe in centers without that expertise, this could have been shown more easily. And similarly, continued refinement of algorithms may be required. Well, I don't know. Just to finish, saying that the funding of this trial was supported by the Portuguese government agency, Agência de Inovação, by the University of Porto, by the UK Portfolio Research Network, and by Speculum Lisbon, who commercializes a program worldwide. And finally, I would like to thank all the patients and all the members of the research team whose contribution was so important for the conclusion of this trial. Thank you very much for your attention.
How many, do you know, now that the trials are finished, right, how many of the centers that did the trial are still using the respective systems, and how many have opted out? And do you do any why we don't do any kind of post-trial monitoring just to see how things are after the heart trauma effects finished? So that's question number 1 to both of us. Yeah, then I'm going to ask you a smaller other one, and keep the rest for later. In principle, so especially Professor Brocklehurst was very positive. You made it quite clear what are the good points of your clinical trial, and I think that was good, well presented. You didn't mention any negative points. You didn't mention anything critical. Is there anything you would change if you could turn back time? Obviously, not doing the trial is not an option. Turning back time, is there something that you think maybe you didn't do quite right, and with hindsight now you would do a bit better? Were there any weaknesses of that trial that you could have potentially prevented? Same for Inês, which, although she's been a bit more critical here in her presentation, but saying if you could turn back time with hindsight, what would you change? And the first question was like, do you know about the centers now? What happens after the trial's finished?
Well, I'm sure it's probably the same for both of us. Once the trial's finished, funding all stops. In fact, funding stopped before we published our trial, so we're limited in what we can do. We know that some of the centres are still using the software, some of them are not. We know that some centres are buying the Guardian SIF system. as some are deciding to have the infant system with that, some are not. But we haven't systematically surveyed the UK to find out what's going on at the moment. The trial only came out in March, and there's been a lot of controversy.
I mean, the centres that were participating, the centres that already had the system on, the centres that participating centres.
We know that some of them have turned them off. The other thing, interestingly, I had quite a long discussion with a couple of the PIs from the centres recently. They've also turned off the central monitoring system in their hospitals. Although some of the centres like the central monitoring ability, some of them think that the midwives are spending less time in the room with the women and more time looking at the screen centrally. So they switch the central monitor off so that midwives have to be in the room, women are having continuous electronic fetal monitoring. Now that's only anecdote from 2 of the centres that I was discussing with a couple of weeks ago, but there's certainly some concern about that. But some people are using the infant software, some people are not. And I'm sorry, we haven't quantified it.
Yeah, me neither. I really don't know. I really don't know if the centres continue to use the SIS portal. Austin was here, but he abandoned the room. Maybe he could answer that question regarding St. George's Hospital. But definitely the funding included the use of the system after the trial has been finished.
Okay.
Yes, so all the centres, the 5 centres have the system available for use. But yes, I would like to stress that point, that midwife thinks that it's probably not a good idea to have central monitoring because they spend less time with patients, and that is one of the issues.
Let me just clarify as well. The software would, both softwares, I think, would be able to raise the alert and do in the room as well.
Yes.
Yes. They have choice. It's not
yes.
Okay.
Yes. And another thing is that most of the centres only had one monitor with the system.
Yeah.
But actually, we can use many monitors everywhere. So actually, they can be everywhere with the patients, without the patients seeing the system.
And to the other question, which insight?
So I think let's just tackle one issue first of all, which is this issue about the Hawthorne effect.
Yeah.
Often used to explain a null result in a trial, not often true. I don't think we had a Hawthorne effect. Our primary event rate was almost 3 times higher than we anticipated. We were all surprised how many babies were born in flat condition in these 25 UK units. That was substantially higher than we thought it was going to be. That to me says that if there was a Hawthorne effect, it must have been very, very small, because we were surprised how high the event rate was. So if people were learning, they weren't learning good lessons. There was a difference in our process outcomes of fetal blood sampling and repeat yellow alerts. So we were changing clinician behaviour. Those were big differences, but considering that most babies don't have a severely abnormal CTG, those are quite important differences. So we showed differences in behaviour between the 2 groups. So if there was a Hawthorne effect in our trial, it was very small. What I would have done differently, particularly with our trial, is that when we first started, we had assurances from the company that were producing the hardware and the software that when they introduced it into a centre, everybody was having intrapartum care would be on the system. So we could look at the routine data before they came into the trial, during the trial, and then after the trial. And that wasn't the case, unfortunately. So many hospitals only switch on the system when they start continuous electronic fetal monitoring. And then the issue about accessibility of those data, once the trial was over and we had the results, it would be fair to say that the relationship between the investigators and the company broke down somewhat. So we weren't able to access those data. But I think it would have been very, very useful to explore exactly what you've suggested happened in your trial, with practice beforehand, practice during and practice after. The other thing I think we need to bear in mind is that we hadn't anticipated, despite how many years this trial was in the planning, I think like yours, we've been planning this trial for a very long time with a lot of different experts involved. We hadn't really thought through what CTG, continuous electronic fetal monitoring, would do for women coming into the labour ward at term. So women may present with an abnormal fetal heart rate when they first present. They may present with bleeding, they may present with a cord prolapse, they may present with an abruption, they may present with complications, which no amount of decision support will make a difference to. Those women will be dealt with and things will happen, and they are the ones most at risk of dying in labour or shortly afterwards. The women that we're trying to make a difference to are probably, not exclusively, those who probably have a normal CTG when they first come in, and that deteriorates during labour. Well, that's, at term, very, 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 very few labours do that. And therefore the mortality event rate, I think, in retrospect, is probably what we suspect it should be. Because those term deaths are not that group of women who have a normal heart rate that then becomes abnormal to the point that they're so sick that they die. And I think that would have been helpful to know in retrospect, although I suspect what that would have done is increased our sample size even more and made the trial undoable.
But what would you have done? You would have excluded these cases from the primary.
No, they were already excluded. They didn't come into the trial, did they? They didn't get randomised into the trial.
There was the recruitment issue.
Yeah, so no, it wasn't a recruitment issue. It was just that our mortality outcomes were very, very low. And that's probably because it's not the sort of women who decision support would make a difference to, because those women are already not included in that process. Now, if we had recognised that earlier on, then we'd have probably been even more pessimistic about our sample size estimations, which would have probably made the trial even larger, which may have been the threshold for it not being supported or not. So, in retrospect, it wasn't a bad decision to go to, because we do have now data on 46,000 women in infant. But yeah, there are things I would have done differently. We didn't know about the Hawthorne effect until we got to the end, or if there was going to be a Hawthorne effect. And the only way to deal with that is to do a cluster randomised controlled trial. Well, to do a cluster randomised controlled trial using our primary outcome, we couldn't have done in the UK. It would have probably taken most of Europe to do it, because the sample size was millions and millions of women. And so we took that decision in the knowledge that there may be a Hawthorne effect, and then crossed our fingers and hoped that there wasn't. And I think in the end, we weren't persuaded that there was a significant Hawthorne effect.
Yeah, well, I think most of the things we have thought about, actually Peter has already stressed, and one of them is the problem of Hawthorne effect that we actually couldn't evaluate properly. And if we had the data for it before the trial, during the trial, and after the trial, we could have solved that problem. But I would like to pick up on something that you've said, Peter, and probably there was. I wasn't there in the design of the trial. Maybe Austin can help us here, but probably we need to find another primary outcome. And I don't know. I was not very comfortable with the metabolic acidosis outcome. I think it's too limitative, and we are probably not searching the right thing to look at. And one of the reasons is the one Peter already said, that the highest group is immediately excluded in the beginning. So we are looking at another group, the intermediate group, and for them probably these outcomes that we're looking for are not good enough. As a way of studying if computerized analysis is actually worth or not.
Anything else you would have changed? Would you have done RCT? Is RCT the best form? What should we do in the future?
I think so. Yeah. Well,
I think that there are so many differences between centres, there's so much potential difference over time, that if you don't control for that by using a randomised control trial, you'll get into the situation where, with very rare event rates, even uncommon event rates like metabolic acidosis, you can begin to explain away that by residual confounding or other biases. And I don't think that policymakers and funders of health services would be as persuaded by evidence from non-randomised controlled trials.
trials. So no matter what you think about randomised controlled trials, they are there, that policymakers do look at them, they take notice of them, and they will fund interventions based on positive results from trials. So I think it is the right methodology, and I don't think that the trials failed to show a difference because they were trials. I think they failed to show a difference because there was no effect of the intervention in the two trials.
What I think, I'm not an epidemiologist, and so I'm a bit ignorant regarding all the trial designs and studies that we can do. But I'm not just that comfortable regarding randomized controlled trials. Actually, they were, as far as I can remember, they were designed to test therapeutic approaches, not diagnostic tools or screening tools. So will them be the right way to go? I don't know. I truly don't know. I don't know.
I think one of the criticisms that we had when the infant trial was published when we were going through the review process, I think it was in the publications, the letters afterwards, was the fact that with a screening trial or a screening test trial, you can choose to prescribe what happens as a consequence of the screening test being positive, or you can leave it to standard clinical care. Now, clearly, if there's a new screening test that's coming out, then you need to prescribe some actions that follow on from that. With something like this, we argued that actually this wasn't different from what people did. The learns weren't any different. This is what obstetricians and midwives do all the time. They see an abnormality in the CTG, they interpret it in the totality of the evidence they've got about that labour and make a decision. All the system was doing was telling them that the CTG was abnormal at this point and not allowing them to interpret that. But then the actions that follow are the actions that follow when they currently interpret a CTG. And what was clear from the quality of care stuff we did is that there were lots of other things going on in a busy labour ward in the UK that meant that people didn't necessarily act as appropriately as they did do. So some women were, the CTG was recognised as being severely abnormal. There was no anaesthetist. The labour ward was, the theatre was full. The woman waited an hour and a half before she had her caesarean section, and the baby was born profoundly encephalopathic and died. It wasn't because they didn't recognise the CTG abnormality. It's because they couldn't do anything about it, or they could have probably done something different about it, but they didn't act appropriately because of all the other things that were going on at the time. And like a lot of these situations, you are embedded in the system that you're in. Interestingly, both our trials were run in the UK at very similar times, where the UK health system is such that we had challenges with delivering what could have been considered the best quality care at the time.
Okay, thank you very much. I think there's a few very good people. Okay, I'll do in order.
I just want to comment on Peter's pessimism about EFM. EFM was not introduced, as far as I understand, to prevent cerebral palsy or outcomes like that. It was introduced to prevent death in labour, fetal death in labour, which was common pre-1970s. And as EFM came into use, it became more and more rare. So now, as you found, as you noticed, it's profoundly rare. And if you study intrapartum stillbirths in a modern unit, most of them had some issue which would mean that monitoring would not have prevented that stillbirth. The baby was known, for example, to have a congenital malformation, and it was deliberately decided not to monitor its health in labour, that sort of thing, or a sudden abruption, as you mentioned. And I think that rather than, if you then say, well, what would happen if we stopped it? Well, would all those stillbirths, intrapartum stillbirths, re-emerge? I think they would. You may not think so. And if they would do so, doesn't that mean that the current system works, whether it's computerized or not, to prevent those intrapartum stillbirths? And you can't improve it further because it's already as good as it can be, whether it's computerized or not. What is bad is the false positive rate. And this is because it is very difficult to calibrate on that grey zone, which is means that people fail safe and they tend to over-respond because the trace is moving in that direction, but they overcall the situation. And that's where computerized measurement might work very well. So Inês asks, we need a new primary outcome. I think the primary outcome should be intervention for fetal distress with a normal outcome.
Yeah.
And accept that obstetricians are pretty good, that they call it right even when they look at the case within the limits of their system and so on. And you can't make something that is being done as good as it can even better. Now there are in this system outcomes of bad long-term outcomes for the babies, which are probably not preventable by intervention in labour. The intervention is not going to cure them of that outcome, and you can't therefore improve upon those. So it's the overcalling of the anxiety about death in labour or near death in labour, which I think should be focused on. And I think the assembled audience here and you have a lot to contribute on that.
Thank you. Any comments?
I would just like to comment.
Few main questions.
Very quickly. Thank you very much, Grace, for your intervention. And I think that was my, well, it was a little bit not very obvious, but the last table I showed you regarding intervention was a bridge for this discussion. What I think we should look for is for intervention rates, decrease of crash cesarean sections, instrumental deliveries because of non-reassuring fetal status. I think that's the way to go, probably. And maybe observational studies, I don't know, getting back to that.
I mean, I think there are two things to say. One is that even without continuous electronic fetal monitoring, I'm not suggesting that we should have any monitoring in labour. And I think there are two broad categorisations of them. Those where intermittent auscultation raises a concern, and then people will look at fetal heart more closely. There are also lots of women who've got clinical risk factors where they are put on continuous electronic fetal monitoring pretty early in labour for the duration. We don't in any way currently know, because I don't think we've ever looked at it, what the different risk profiles are for those different groups. So we have quite a low threshold for using continuous electronic fetal monitoring. And it may well be that if it was a higher threshold, we would decrease the false positives and increase the number of true positives within all the positives that are coming up, because we would take a group at higher risk. So I think there are ways in between my very deliberately provocative stance of saying get rid of CTGs from where we are, which may be about refining the way we use CTGs so that we minimise the false positives while maximising the benefit of them. And I think there are also, I mean, the other thing is there are all sorts of questions about intermittent auscultation. You know, we practice intermittent auscultation in this country the same way that we have done for decades. Nobody's ever looked into that and how effective and useful that is. But it's built on the same principles, obviously, as CTG interpretation. So there are still questions about how we currently monitor fetal heart rate.
Okay, Martin?
I would like to attempt a step back at the perspective of interpretation of the results. I certainly have a bias as a father and as a perinatal scientist in the value of the heart rate monitoring. So this is disclosure up front. But I see it as a resource that's invaluable because it's the only thing we have. As both of you have said, this is the only thing we really have. And the question becomes, the concern that people will say, well, it's really not worthwhile and so on and so forth. What I would like to propose is a perspective change and say, because it's the only thing we have, and we really don't know, is that the bottom or is it as good as it may be? Are there other ways to acquire it? Perhaps it should simply be something that by default is always there, and the studies are essentially, they shouldn't stop. There should be an infrastructure where we're always able to record data without having to well, we might have to do the consent form, but the data should simply be available as part of every child, especially in healthcare such as the one in the Cape. In the United States is a whole different thing, unfortunately, but there are a number of healthcares, especially in Commonwealth countries, that where it should be conceivable to simply record everything. And I say that think of it as something that we do in oncology, especially in pediatric oncology. Every child is on a study. We don't even think it any other way because it's inconceivable to just accept, the death as the option. Thankfully, the death is no longer, the likely outcome as we have discussed, but there's still a number of long-term outcomes we're always underpowered to appreciate because we constantly start a new study and there's always issue sample size. So I think really the only solution in the century we're in is that the data should just always be acquired. And it's not an issue of storage, it's not an issue of technology, it's just a question of will. And a number of people that would agree to say we should do it. And I don't know if it's too bold or naive, but I think that's, to me, the main conclusion from what I've heard.
Thank you, Martin. I think it's possible. The technology is there. It's possible.
I mean, just to comment on that, when we first started Infant, because it was so long ago when we were planning it, the storage was a real issue. And then Chris Redmond and I have had some very disappointing conversations on the fact that I don't have any CTGs. All the data's, we had the alerts, we had various features of the CTG downloaded to us. And if we were starting this trial now, we wouldn't worry about the storage space. We'd get all the CTGs downloaded for us. They're not, they're still in the centres. But I agree those digital traces are in those centres. We should, and there's something, the Guardian system, the K2 system, which records all clinical data electronically, means that those centres that do use it for all women have got masses of data in there. Now the accessibility, the readability, and the being able to collect that is an issue. But issues to do with consent may not be as big as you think. If those data sets can be effectively anonymised, they can be shared without consent. So there potentially are hundreds of thousands of data items out there which, if we could get together, would be enormously powerful.
But there's a massive problem, even so, which is the treatment paradox. And you mentioned about randomized trials. It is true that for a screening test, you don't need a randomized trial. In fact, the best way to assess a test of diagnostic accuracy is to administer the test, blind the person to the test result, and see what happens. This is how you evaluate screening tests. The problem we have is that this screening test has been in practice for so long that no one would accept such a study of recording the CTG and not acting on it. Are there models, statistical models, that can correct for that? Are there animal models that could teach us things now that we haven't learned in the past? Is there any way around this? I guess is my question.
There aren't statistical models that I know that can adjust for that, because it's impossible to know what the treatment effect is within that treatment paradox. And you'd have to do a lot of assumptions for it. I mean, the one thing that has been suggested, of course, is that there are populations.
Yes.
There are populations that don't have access to this technology. Whether it would be considered ethically acceptable to record this information and conceal it, as in not reveal it to anybody, just record the information while women were going through their normal care practices, I don't know. But that's the only way you get their true natural history. What Chris was mentioning in terms of the intrapartum stillbirth, that's the only way you get that. But of course, the populations that we're talking about are very different from ours in terms of other things that lead to adverse perinatal outcomes in terms of their general population health and so on and so forth. But that, I think, is probably the only way you could truly get at the impact.
It's almost inconceivably difficult to discuss these issues. Colleagues who run a centre in Zanzibar, where stillbirth is a daily occurrence, where there is no fetal heart rate monitoring. Nevertheless, it would be almost impossible to implement a system, as you say, without revealing some of those things.
Before I let Patrice ask you a probably more technically related question, I wanted to. So my question about his side, both of you responded to it as clinicians. Excellent, but none of you actually even touched on the possibility that these softwares could have been tested, improved, and so on. So I just want to make a comment for you to Patrice, which is okay, but you think as clinicians, absolutely. And maybe with time we can integrate more and get you to think and other people to think a little bit more in the higher. Patrice?
Yeah, no, so my question is not technical. My question is respond to this provocative statement that chemoprocessing is useless by a super naive question. Now I don't understand the role of this FIGO criteria, because for me, when I was given the FIGO criteria, it's written like an algorithm. Like, if deceleration lower than this in that, then do that. So if it's an algorithm, who can do it better than a computer? Okay? So now if you tell me that any computer thing is useless, then what's the point of writing an algorithm and providing it to the doctor saying, please follow the rules? So please tell me something about that.
Well, you're assuming that the development of the algorithm and the FIGO guidelines was based on evidence and good, strong data, as opposed to the views of a few people thinking that was a good idea. So if an algorithm doesn't work when it's handled manually, it's not going to work when it's handled electronically, I would suggest. I think that the associations of those features with the outcome are not unreasonable, but what I think both of our trials tested was the addition of that extra level of objective interpretation with what the clinicians currently did. And I think what we both concluded and Chris suggested was that actually our clinicians in this country are pretty good at that. Midwives and obstetricians are pretty good at looking at those kind of really, and I think the other thing is that if you're looking at things like stillbirth and neonatal death, you're usually, and that's due to intrapartum hypoxia, you're looking at really starkly abnormal CTGs. And those, I suspect, are less frequently missed than those where the signs are much more subtle. So I think we're probably pretty good at that. I think we still continue to beat ourselves over the head about it, but it's still pretty good.
So,
As from the perspective of a clinician, with a long view, I guess, but who always asks questions. A second very popular reason for the adoption of electronic fetal heart rate monitoring in the United States was promulgated by people like Ted Quillis, very, very good academic and administrative obstetricians, who discovered that they could staff their labor suite with fewer personnel if you had an electronic monitor replace the nurse or the midwife at doing auscultation. The same extension of that goes to the centralized monitoring system. So the question is, why did you use electronic monitoring? Why did you adopt it? And we're using it for things that it wasn't designed to be used for, which is to diagnose. It's real simple. I can look at 20 randomized, controlled, double-blind, crossover studies, and then when it's all over, the first place I have to look at is the methods, because I want to know if these patients represent my patient. But the problem that the clinician has is he's not taking care of the births in Europe or North America. He's taking care of Mrs. Jones right here. And the data he's collecting either has to support or refute the thing that he's been told to be concerned about. So I think the first thing that needs to be done is we need to define what the goal of any of this research is, all of which I think is very valuable and of which I'm a part of, whether it's algorithms or whether it's clinical care, be precise in the question that's asked and what the goals, what's the hypothesis, and how do we get there, and how do we design the studies. And I think that it's naive to think that you can take an electronic signal and make it, analyze it 20 ways to nowhere if you don't know where you're going and expect to get someplace. By the same token, you can't ignore the patient, the woman, with her comorbidities. A very simple question that I would ask with all of this tracing is, were the diabetics excluded? Were the hypertensives excluded? Were the preeclamptics excluded? Were the women with the diagnosis of intrauterine growth retardation excluded? How much of the decrease of stillbirth, intrapartum death, bad babies in the nursery are those numbers being down? Are they a result of the use of antepartum ultrasonography to image a baby, look at its behavior, look at its growth, and remove it from the pool of patients that are going to be randomized, and therefore increasing the power of any randomized trial that you're going to have to do after you've taken all the high-risk patients out. So that's my comment.
These are very valid points, but this is a larger problem with evidence-based medicine. And this is the a problem, correct me if I'm wrong, in absolutely every field of medicine at the moment. When we have we want to have evidence-based medicine, we do RCT trials, but there are problems. In Oxford, there is Evidence Live, there is an annual conference where people could get together for 3 days and argue exactly about these things, where it's applicable to the individual. So you're right, but this is a bit out of, so thank you.
Well, it took 20 years for 5 million American OBGYN to come up with a consensus classification of fetal heart rate tracings. Now, with any additional evidence, and without using any clinical data, they're now trying to tell us how to practice obstetrics using that classification. It is ludicrous.
Okay, okay. Thank you.
I think it's actually captured a number of the points I wanted to make, but I'll pick up on 2 further points, one of which is Inês's question in terms of what the process was during the conception of the trial. So we published the first 1,500 cases of STAM monitored at St. Joseph's Hospital.
Sorry.
Can you speak up?
No. Sorry.
Sorry, my voice is not as big as I am. It's a constant problem that I have. So I'll just say that during the design of the Cispoto trial, we went with the metabolic acidosis rate that we published in the first 1,500 cases that were monitored. Except that the cases that were monitored were a highly select high-risk group. So you didn't get monitored on STAM unless you had abnormal CTG, or that the CTG was sufficiently abnormal to prompt the clinician to want to do fetal blood sample, those sorts of things, or they were growth restricted, So they were a really, really highly selected group. So the metabolic acidosis rate in that group was 2.8, which is where the sort of sample size calculation came from. There is no way in the United Kingdom where there is a policy of routine acid-based status analysis exists. So we did not have, a baseline metabolic acidosis rate. Now, that explains why the sample size was what it was. But if we knew what the correct background metabolic acidosis rate was, it's almost inconceivable that we would have been able to carry out the trial. I think the Dutch group, when they did their own STAM trial, experienced exactly the same thing. They found a baseline metabolic acidosis rate that was less than half of what they predicted, even in their own unit. The other point I wanted to pick up on is your suggestion actually that metabolic acidosis perhaps is not the endpoint to look at. I absolutely agree. The fetus does not care about metabolic acidosis. The fetus cares about its central mean arterial pressure. I think there are people in this room actually that have the know-how and the technology to be able to monitor fetal blood pressure. Babies don't get damaged until their blood pressure is kept low. Is Baz here? Baz Lemons? Oh, there he is. Yes, we were having this conversation in just a week ago. So I think this issue about what questions are we actually asking is such a crucial one that we can't keep tiptoeing around it by doing all these fanciful trials. It is such a critical point, and I believe that the technology already exists, and there are people here that are smart enough to put it in place.
Thank you. Comments?
Just very quickly, I would just would like to comment on this last thing Austin referred to. I think we probably have to move from CTG to some other technology. And technology is there. I had a very interesting conversation yesterday with Jerry, and yeah, definitely, fetus blood pressure is very important. Cerebral blood pressure in the fetus during labor is very important, and I think we should probably think about
what technology
something
is there?
else.
I've missed it. What technology is there?
Using ultrasound, Doppler in labor. Things like that. There are so many medical engineers here.
That Dr. Schiffer brought up yesterday about cerebral blood flow.
Yeah.
If you have a method where you can look at the medical
But does anybody have it? That's the problem. I mean, who has it?
We have the technology. We don't have the device, but I think that could probably, I don't know,
Excellent.
be
The
developed.
device is in the United States, the device is routinely sold and used by
I'll catch you to talk about it.
on fetuses.
Got it. I'll catch you to talk about it. I've missed it. So.
Let me comment on Chris's comment that it may be that the only way to convincingly prove the benefits of fetal monitoring is to abandon it. Why don't we see what happens to the death rate, the morbidity rate, the intervention rate? It is not only auscultation is a problem. If you study real data and try to apply an auscultatory paradigm to it, the intervention rate would be enormous because the frequency of decelerations, the limitations of auscultation, and you'd have a huge problem. I think that in relationship to the comments here, that you're going to have to use fetal monitors to understand and implement a change in obstetrical behavior. That's what we're after. We're after reducing the rate of, we think, and I'll talk tomorrow about emergency interventions, certainly, and that I think is the beginning of wisdom of lowering the overall cesarean section rate. If you can get rid of the need to intervene emergently, and perhaps we can agree that if there is a measure of the quality of care, okay, in a patient undergoing a trial of labor, there's a normal fetus going a trial of labor, the need for an emergency cesarean section under those circumstances is in fact, I believe, a measure of the standard of care. Finally, let me try something. I understand, as I tried to point out yesterday, what we are after is cerebral perfusion. That's what you're after. That's a function of the blood pressure, that's a function of the pressure on the brain, that is a function of the baby, of the ability of the baby to respond. And you must understand, a baby has extraordinary defenses against impairment of cerebral blood flow. It has extraordinary defenses, but those can be overcome. And my suggestion, not based on data, is that the answer to the questions of perfusion, cerebral perfusion, lie in the proper interpretation of the heart rate pattern, because that is going to tell you about the sufficiency of cerebral perfusion, because in great measure how the baby responds with heart rate is a function, okay, of its neurologic capacity. And you have that the fetal monitor is not simply a window on the amount of oxygen the baby is getting. It is on the ability to perfuse the brain, perfuse its central organs, and an insight into the mechanisms it is using to fix the problems, and to fix the problems it has. So I think some of the things that would be nice to know, the blood pressure, as I tried to show you yesterday, it would be nice to know the blood pressure, it would be nice to know the CPP, cerebral perfusion pressure, it would be nice to know all of these things. I'm trying to suggest, at least in the normal baby, you will be able to extract all of this information from properly interpreted fetal heart rate patterns. Thank you.
Thank you very much. No comments from you? Yeah? Okay. Sorry, I interrupted you the previous time anyway.
No, that's fine. No, I think we have got a very nice overview of what we have, what we can actually improve.
Okay.
Probably we should think about a group of discussion. I think probably we should be together, I mean, a group of experts thinking about what we can
actually do right now, because I think we are in a kind of how is it? I can't find the word in English, but like well, we have come to an end yeah, we are stuck in the middle of
Can
and
I?
probably
I disagree that you need more expert consensus.
Yes.
I think when you get experts together, you come up with statements like the FIDO statement. I think you should let the data tell you what the answer is. You
But
have
I think
hundreds and thousands of gigabytes of data around the world of babies being monitored. You should mine that data. Don't put your perceptions of what is normal or abnormal from clinical experience first. Play the data, and going back to your point about machine learning earlier or deep learning earlier, and see what the data say. What are the features that are associated that you mentioned with poor cerebral perfusion?
Well, but I don't think that was the point you were making. I don't think. I think it was. I mean, when a baby's in the neonatal unit, you wouldn't just measure its pulse. There's no way you would do that. It'd be pointless. It's a single measurement. It's not that good. I don't believe it's that good for a fetus. You have multi-parameter measurements to look for well-being.
Sure.
If we just continue to look at fetal heart rates, we will inch forward. I think we need to look at much more. We need to look at new forms of imaging. We can do so much more in terms of our imaging technology. We need to talk to our engineers. We need to talk to our metabolomics and our proteomics.
Yeah,
I can quite imagine a probe which sits on the baby's scalp, which could measure dozens of metabolites now, which may be better predictors if combined with fetal heart rate. You know, we're still pursuing one parameter. And I heard what you said was we should get all in a room with everybody and say, how can we monitor fetal well-being in labour?
better.
Not just
in
fetal heart
21st
rate.
century,
In
with
the
the
21st
current
century,
technology.
because the technologies are progressing incredibly rapidly.
Exactly, yeah.
Engineers, I meet with engineers now in other aspects of my job, they can think about ways of doing things which I've not even conceived of.
Thank
you know,
you.
that things that makes Star Trek look primitive. Whatever sci-fi it is. So I think we need to broaden the scope out about how we monitor intrapartum well-being.
Absolutely.
Thank you.
That I
No, but that's what I'm looking.
Yeah,
Okay.
Peter is being pessimistic again. The fetal heart rate is a bit more than just the heart rate. I think the control of the heart rate is actually part of what you're monitoring. A baby is not going to show you a normal fetal heart rate pattern without the connection between the cortex, the midbrain, via the conductive tissues of the heart onto the muscle itself not being intact. So it's a bit more than just counting the pulse. That's number one. But I just want to pick up on Barry's point before we move on, which is this, that in our center we looked at 8 years of monitoring, and we found 65 neonatal encephalopathies. We normally would interpret our CTGs in a standardized way. And if you apply that standardization, only one baby of those 65 actually met the diagnostic criteria for metabolic acidosis, suggesting to me that the answer is somewhere else. And actually, one of the things that is wrong with the way we approach this subject is the way we teach CTG, the way we discuss it, and perhaps what ends up in our guidance. So, you've touched on something that is really important. Unfortunately, we submitted that paper to VJOG. It was turned down, which anytime VJOG turns down a paper, that's a good indicator that it's actually a good paper.
I don't think I'm telling tales out of school, but as a member of that committee, it would be nice to reveal all the data. And the data is all the exchanges that went back and forth. There were exchanges on why 3 categories. And so much of what you ultimately see is what you would have expected out of a committee. And it is not data-driven. It really isn't, and we need to change some of the perspective of what we're doing on labor and delivery, what we're trying to prevent, what we're trying to assist with. And I certainly agree, it is not the pulse of the baby. It's not something, it is a heart rate pattern, it is a heart rate rhythm, it is in fact, a vital rhythm. And I think that's how it has to start looking at it.
Thank you. You will have a chance tomorrow as well. And it's not too clinical. Can I try to shift it a little bit more in the remaining 5 minutes before lunch? A little bit more towards the technical side of things. And it's what we try to do in this forum here is bridge the gap. And every time we do it, it's only the second time. It's so obvious that there is like a crater. Did you hear any signal processing person talk now? One thing I want to mention is, for example, that if you go back to the results of infant and you see the red alert is 11% in the overall population, that tells you already that that's a pretty high, for the red alert, pretty high false positive rate because you wouldn't have 10% of babies dying. And when you read the paper on infant, you would see that, for example, 50% of this red alert, about 30% of the 10%, had to do with like a false baseline. So, and this is something that research midwives, ordinary midwives, never underestimate the ordinary midwife. That's my conclusion. She had noticed that very early in the infant trial that the software is doing that. If you have a very reactive phrase and then the baseline goes back to normal, this thing starts shouting, there is a problem, there is a problem. Midwives disliked that immediately. They mistrusted this readily. There was no reason, in my opinion, to spend £6 million in 6 years on a software that does that, given that technologically you can fix this in a day. So if this software was tested very briefly, even as a blinded, as we were discussing, instead of just tested before you do such a, technologically you could have done so much better. With the infant, I'm not against the infant software, there is a difference when you're on your computer and when you're in the real delivery work. So you want to be testing your new algorithms, and that's something Jean-Francois mentioned yesterday from Monica as well. You want to get this very good on the bench before you go, and you need to do all this kind of phase test. So that's just, I wanted to mention my opinion from technical perspective. You could have done so much better. I'm not sure about the CIS portal because there's been a lot of work there already. But in terms of the software, you could have done better before you roll it out.
I mean, it's not dissimilar to the discussion we have all the time about clinical trials. At what threshold do you say, well, now you can do a clinical trial? It's not even that dissimilar with drugs, although people think that's much more precise. It isn't that much more precise. The level of evidence you need to persuade somebody that your drug does what it says it does and therefore is worth testing in a trial is not that dissimilar. But we have it with behavioural interventions, we have it with all sorts of interventions. And there was a lot of discussion about this, and ultimately, because this was the second biggest trial in terms of money ever funded by this funder, the previous one being the prostate cancer screening trial, which is currently at £38 million and climbing. This was the second biggest one. It got more peer review than anything else that had ever gone to that board before. And there was those discussions backwards and forwards, and it was felt on balance that the technology was at a stage where it should be tested.
Were the engineers involved in that discussion is my question. That discussion was between...
There have been some of them. I mean, the other thing at the time, of course, the technology, the infant technology, already had a CE mark. It had been approved for clinical use. It had persuaded the regulators that it did what it said it would do and was approved for clinical use. The company did not use it clinically because the trial was at the stage of being funded, and therefore we tested it. So it wasn't released and marketed at that stage, but it had persuaded the regulators, which are stuffed full of engineers and very few clinicians, because some of the clinical comments that came back to them were odd. So it had, I mean, I don't disagree with what you're saying, but it had persuaded a sufficient number of people that this was ready to be tested in the trial, that the trial went ahead. Was that the right decision? You know, I'm sure there's debate about that, but it was a decision that was taken.
The very big point I wanted to make is that this is extremely easy to fix technically. This doesn't require a year of anything. You could have tested it. An ordinary midwife would notice this did notice this with infant, from my personal communications, within a week, you could have run it for a week. Anyways, that's very easy to fix technically.
Just to mention the elephant in the room, I think the room that you were hoping for is this one. We have the epidemiologists, we have the clinicians,
Good point.
we have the research biomedical engineers, we have the medical device industry represented.
That's the room you're talking about.
This is the room.
Good.
The physiologists, sorry, I almost forgot that.
Well, that sounds perfect.
Let me just get any last comments before Barry takes again, and then we can finish with Barry. Any brief comments before?
Super quick comment. First, there is absolutely no contradiction between the fact of, given that RCT is the only available thing at the moment, and the best of it, and having new data collected. This is just complementary to
Yes.
your position.
Yeah.
And for single processing people, the more data, the more fun, so it's great.
Yeah.
Second point, and it's again a super naive question. I assume that midwife or doctor, before going to a delivery room, receive some training and education and information. So this probably is a background on which some computerized something can be constructed. Otherwise, I am a bit lost about what the training and information is about. So I am still, I don't want to come back on the figure pictures, but I am still confused and not understanding very well how the common training background cannot be put into some kind of formal system somehow. Because to be taught anyway, it needs to be formalized. Or is it too naive?
So I think, midwives and obstetricians are trained. They are regularly trained on CTG interpretation and analysis. And despite that, we still have adverse outcomes happening in the population. And that was the justification. The hypothesis was that Phil Steer, who some of you will be aware of, had a belief before the infant trial started that there were some clinicians who weren't able to recognise abnormal patterns. And he felt very strongly that there probably should be an entry test into midwifery school, which was if you were unable to recognise patterns, as in a form of dyslexia, you shouldn't ever become a midwife, because you couldn't look at a CTG and spot the pattern abnormalities. I don't think he's persuaded that that's very common now, because it didn't make any difference to the trial, but he thought that was quite a common trait, that people had a difficulty recognising abnormalities. When I was a clinician, I know it was 1,000 years ago, but when I was a clinician, the consultant would come around in the morning when I was a registrar and show people traces and ask them when it became abnormal, and they'd point their finger on and say it became abnormal then, and then he'd say, well, why, he'd sneakily got a trace from last week and said, well, why did you sit on that for another hour and a half? So there is something about how people interpret data coming out in real time and how they can look back and recognise. So there are issues with pattern recognition. So in theory, computerised interpretation should take that human element out of it. And I'm sure it does to an extent, but it didn't make a difference in our trials that we could detect. So either it isn't that big a difference, or the CTG abnormalities that we're looking at are not an academic issue. It's like, is there a bit of change in variability there? But when you're talking about clinical outcomes, they're often pretty big things if that's the cause of the adverse outcome. Do you see what I mean?
Peter?
This is a question for all the medical doctors in this room. What is that you would like us engineers to deliver for you when we design these algorithms? So what questions do we have to answer without algorithms? Could you tell us what you want us to do?
He keeps on asking these questions, so I'm not going to allow a lot of time on it. Your perspective.
That we can deliver. What is that you want us to do?
Well, it's
from ideal engineer.
Ideally, it's straightforward in principle, but it comes back to this treatment paradox that we don't actually know because we intervene. If you had a population that wasn't being intervened, then we could easily answer that question, which is we want something which is very high positive predictive value with a low false positive rate, which tells us those babies that are going to be damaged if we don't do anything. Now, within the current Western environment where we do all this fetal monitoring, that's much more difficult to get a handle on, because if you believe the paradigm that is not universally accepted, I have to say, but if you believe the paradigm that what we're currently doing is identifying
changes in the fetal heart rate that predict adverse outcome and therefore intervene to stop those adverse outcomes, and that is an assumption of progression through that process, then it's quite difficult, because if a baby comes out healthy and pink, doesn't mean that it wouldn't have come out dead if we'd left it another hour and a half. So I'm not underestimating the challenge there, but there are those babies we know currently who come out in a bad way because people have mismanaged them. And I suspect in those instances we can learn an awful lot if we can understand what's happening in those pregnancies. But that's all collecting information retrospectively. So I've been talking to somebody in London, Professor obstetrics, well, I don't think she is, but Lucilla Poston, who's very interested in seeing whether she can think about collecting very early samples for metabolomics on those babies that are born unwell, and seeing what metabolomic patterns are represented there. But of course that's the end stage of those babies that are represented unwell. So I'm not saying it's an easy job, and I'm not a physiologist, but I just think there could be things that would be better than our current methods.
Thank you. Any comments, Inês?
Yeah, I just want to add that probably a database that starts early in pregnancy, in terms of data regarding pregnancy, together with data during labour and delivery and afterwards. So a big database with information just from the beginning of pregnancy until late could help us understanding a little bit better what we are discussing now. And for that, in Portugal, we started in the University of Portugal as well, a database that collects data in the outpatient, just from the beginning of pregnancy, in the outpatient clinic, and then goes through the labour and after that, and probably could help us.
Yeah, we've been doing that as well.
Yeah.
Okay, Barry?
Sorry, just before that, can I come back to that previous question, because I don't think I answered it as well as I could have done, which is, the other thing we can do is improve what we've got, because the treatment paradox is existing. If we could come up with other technologies which would decrease the false positives while not compromising what we believe is the current sensitivity, those would be fantastic steps forward.
Absolutely.
It would stop the false positives, the diagnosing and
then you could
intervening.
monitor more people as well and get more data.
Yeah. So there are ways of not starting afresh, as it were, with a new, but adding something to which would help, make more refined. Because if you're doing a screening program, if you think about the cervical smear screening program, we do the smear, and then if you've got a positive smear, then you have a colposcopy, and that's the second screening. That doesn't compromise the sensitivity, but decreases the false positives. Now, you may argue we still have a lot of false positives, we take a lot of cervixes out, but it cuts down at various stages of the screening. So multi-stage screening is a way of overcoming something which is very sensitive but very non-specific, as long as it doesn't compromise sensitivity at each stage of the screening process. So maybe that adding...
That was the fetal blood sample, which is...
That was the fetal blood sample tradition.
And now the stand,
and then the stand.
And the stand.
Peter?
No, that wasn't the fetal, sorry to interject. That wasn't the story with the fetal blood sample. The fetal blood sample and the CTG do not operate independently.
Yeah.
You have to have made a diagnosis that this CTG highlights a possible risk of abnormal fetal blood sample. Therefore, if your CTG interpretation is rubbish, your fetal blood sample is not going to make any difference.
Absolutely.
That's true.
Yeah,
Good
so,
point.
I think we...
Same with that,
One additional challenge is actually for us is to understand what do you consider a false positive. What is positive?
Because we're going to get the same answer. The question is, what would be the quantitative manner for us to have at end an evaluation of the false positives? Because otherwise we cannot do something if we don't have materials to work with.
We discussed this yesterday. It's very simple. When you look at FHR data, we want them to be labeled somehow. Label with a qualitative, it can be categorical, saying this is good, this is bad, this is good, this is bad. How do we get this information?
I don't think you can unless you blind the test.
You've got the treatment paradox.
You cannot. So if I see a dreadful fetal heart rate monitor, and I take an intervention, I stop the oxytocin, rescue the baby with tibutylin, go and do a cesarean section, the baby comes out beautifully, perfectly, with normal pHs and all the rest of it. That does not mean that had I persisted in my management, the baby would not have died maybe even 15 minutes later. So according to any classification, that would be a false positive. I would say that was a true positive and it was appropriately managed.
But we don't know.
We don't
know.
We
I was going to say, we don't know.
It gets back us to the question of intervention, and probably the intervention is the outcome to look for. Because what we want is not babies.
Yeah, I think there is intervention. And the example Iris gave was a different type of intervention where you actually reduce oxytocin, you hydrate.
What we want to do is to avoid a bad outcome. We want to
but these interventions we are fine with. We are not fine with the crush C-sections, right? We are fine with giving water.
Exactly,
we are fine with stopping the
True.
Okay, she shared something very quickly technically.
Yeah, so equivalent to this, just to kind of elaborate. So, for example, in cancer, there is also a treatment paradox, correct? Wherein you're trying to sort of predict something, for example, in the new machine learning imaging or whatever, that you want to prevent, right? But the exception there is that there is perhaps evidence of a tumor. You can do a biopsy and then predict that the tumor kind of reduces in size or whatever. So I guess our challenge is to find what the equivalent of that biopsy is, right? And I just want to comment that like do you see anything possible for us to kind of find what that equivalent is? Any research that we could do, any kind of imaging, new kind of technology that we could do to find?
See, I think you're asking the wrong people here.
Yeah.
I think you need to ask the rest of this audience. I do trials, that's what I do. I've learned lots about fetal monitoring while doing trials, but I'm not that's not my raison d'etre. So there are people here that's, if everybody's in this room, that's fantastic. Thrash this out, find out what it is.
So the question is actually open, and we don't have to answer it right now.
Can I do a little bit of follow-up on the false positive rate, and then it's really bye, and then really go for lunch, and you have a last word as well. The false positive, reducing the false positives, certainly, I'm sorry you couldn't see my talk earlier today, certainly something at heart of what I do, definitely, it's extremely important. But what I wanted to say is that once I really, really, really worry that I do all the work I do, and then when we want to test it in clinical practice, it will happen what happened with the STAN trial in the US, which was that the way STAN works, you want to say, there is no ST event, sit down. This is a bad-looking trace. This is the second-tier test where you're looking, as a designer, you're looking at these abnormal CTG patterns. You do your second-tier test, like a blood sample or STAN. Then your second test is telling you, don't intervene, sit down, don't intervene. And then what happens if that baby comes out dead, right? So we are talking about screening tests. You know you're going to have a fall. You know you're going to miss some babies. You know you will. So I've got my system. I put it tomorrow. I know that the numbers to some individual babies, that baby is going to die because my software is only a risk assessment tool. And even if it got it all right, even if clinical practice reacted, do you see what I mean? And what I understand in US happened is you put that, and again, very big trial involving many people, a lot of money, and you put this system and you say, okay people, well, let's test it. But in the protocol, you say at the bottom, but if you're at any point really concerned, please use your clinical judgment, because no one wants to take the ethical responsibility financially or ethically to say, well, that one baby, it will be 1 in 10,000, it will die, and it will be the fault that your software is not picking that up well, or your screening test is not picking that up well. And when it's a new screening test and you want to test it, I find this, and I think that's one of the problems with doing a clinical trial with a visual aid, where you just measure something in the CTG and you help the clinician, you leave all the responsibility with the clinician. I know there's been some discussions in the design of infant, how to get the ethics approval for it. You need to leave all the responsibility with the doctors. But if you want to reduce the false positive rate, we need to be prepared to introduce a new tool like STAN or Oxys or something else, which will be telling you, no, don't intervene, and see what happens. And I don't think we'll ever be able to get the ethics for that. What do you think?
I wouldn't separate ethics from what is ethical.
Yeah, me too.
I think you probably couldn't get the ethics from it because people wouldn't accept that as you still need to use your clinical judgment. There is still a responsibility to the patient clinically, and I think that's difficult. One of the reasons we're so keen on intrapartum fetal monitoring, probably less keen than the Americans, but we have huge litigation bills in this country. Now, they're not borne by the individuals, they're borne by the state. But billions of pounds goes into litigation. And so we are governed by that anxiety that if we miss something. And screening, any screening test is fraught by this. Muir Gray once said that screening programs were a zero gratitude business, because everybody you pick up as being positive doesn't like it because they're having to have something done, and those you miss try and sue you. It is a difficulty. All screening programs are inherently difficult to understand and conceptually accept. So, but I think you're right. But we know that the early trial, the intermittent auscultation versus CTG trials were done. So people were able to have a substantially lower caesarean section rate in the intermittent auscultation arm compared with the CTG, which was the standard of practice.
We do it in a way now as well. We say you're a low risk, we're not going to monitor you, and we know that some people that would be the wrong choice for them, but someone judges that the balance is the right. Oh, okay, last one.
The fear that you describe as a technician, it's the same as the clinician has. Therefore, we do too much interventions. And that's the reason that we have to focus on the false positive rate and not on sensitivity. And that's what we're doing, still going for sensitivity. But it's to reduce, to improve the specificity, because we're doing too much and it's underestimated the problems of the come because to the woman, but also to a neck pregnancy with a scar. So we think we're doing the right thing, but it's not emphasized enough that we're doing not the right thing.
Yeah. No, I think that balance between unnecessary caesarean section, particularly intrapartum caesarean section, we're only just beginning to quantify the long-term harms of that. And I think when I was in clinical practice, the urogynecologists just kept telling the obstetricians they weren't doing enough caesarean sections to save these women's pelvic floors, and there was no risk of doing a caesarean section, and it was a safe operation, and it was fantastic, and we should be doing more of them. And now we're looking at the long-term consequences in subsequent pregnancies. And when that balance swings back, I think obstetricians currently have a pretty low threshold for doing a caesarean section, because they're focused on that pregnancy and that baby, without thinking about the consequences of their action now in 2 years' time, when they've got a massive abruption with a ruptured uterus and a baby in the abdomen, and it's all because they had a caesarean section 2 years ago, which wasn't necessary. And until that starts coming through and people start understanding that, it will be difficult to stop their false positives. But I completely agree.
Okay, well, thank you very much. Very final comments from the panelists, and then we can go for lunch.
Thank you.